When counseling centers think about AI documentation, the conversation almost always starts and often ends with progress notes. And that makes sense. Progress notes are the highest volume documentation task in any counseling center, but they are not the only one. At any given point in an academic year, your clinical staff is also producing letters for academic accommodation and disability documentation, treatment summaries for students transferring to community providers, clearance letters, psychiatric referral summaries, and responses to legal records requests. Each of these takes real time. They require pulling from the clinical record, synthesizing session history, and producing a coherent, professionally written document, often under time pressure. And in most centers, this work falls entirely on the clinician, manually, one document at a time. AI can help here meaningfully, but only when the clinical record is structured well enough to support it. That's what this episode is about. Let's be specific about what clinical documentation actually includes in a university counseling center, because the category is broader than most people name when they talk about documentation burden. The first category is accommodation and disability letters. These are among the most time-intensive documents a counseling center produces. A clinician must review the student's clinical history, identify relevant diagnostic information, and write a letter that meets specific institutional or legal standards. The information to write that letter already exists in the clinical record. The work, historically, has been connecting that information into a coherent document from scratch, every time for every student who needs one. Second are transfer and referral summaries. When a student transitions from the counseling center to a community provider, a psychiatric practice, or a higher level of care, the receiving clinician needs a clear picture of the treatment history. Writing that summary requires the counselor to reconstruct the arc of care, presenting concerns at intake, the course of treatment, interventions used, current clinical status, and rationale for the referral. That is not a short task, and it is a task that happens at a moment when the clinician is often already managing the relational complexity of a student transition. Third are clearance letters. These are shorter in length, but still require clinical judgment and accurate reference to the record. They are produced in response to requests from housing offices, athletic departments, study abroad programs, academic deans, and others who need documentation of a student's current clinical status. The pressure here is often speed. These requests come with deadlines. A clinician who has to reconstruct the relevant clinical history before writing a one-page letter is spending time the workflow was not designed to protect. And fourth are responses to records requests and release summaries. When a student or an outside party requests clinical records, the counseling center often needs to produce something more useful than a raw export of progress notes, a summary document that represents the record accurately and professionally. These documents require review, synthesis, and careful framing. They are not fast. Now, what do all four of these have in common? They all draw from the same source, the clinical record, the presenting concerns, the diagnosis, the treatment history, the interventions, the current status. If that information is documented consistently in structured fields across a well-designed template, it is already there. The AI's job is not to invent it. It is to synthesize what already exists in the record and produce a coherent first draft. That is the same principle that makes AI work well for progress notes, but it extends to every document type that draws from the same clinical data. The limiting factor is always the quality and consistency of the underlying records. Centers with well-structured documentation workflows get more from AI than centers with inconsistent or unstructured records. Let me show you what this looks like inside an EHR designed for counseling centers. Here's a student's clinical record. You can see the intake note, presenting concerns, relevant history, initial clinical impressions. A sequence of progress notes documents the course of treatment. Each one is structured the same way: presenting concern for this session, interventions, client response and plan. Now, a community provider has requested a transfer summary. Historically, this is where a clinician would open a blank document and start writing from memory and manual chart review. With structured AI documentation, the process is different. The system can draw from the structured fields already in the record: intake information, diagnoses, treatment themes, intervention history, and current clinical status, and generate a draft summary. That draft is not a transcript. It is a synthesized document, organized, professionally written, and grounded in what is actually in the record. The clinician reviews it the same way they review an AI-generated progress note. They read it, refine it, add clinical nuance, and sign off. The AI produces the first draft. The clinician authors the final document. There's an important distinction worth naming here. AI can support this kind of documentation effectively because the documents are grounded in the record. The AI is not generating clinical opinion from nothing. It is organizing and summarizing information that was already documented, session by session, by the treating clinician. That distinction matters for clinical accuracy, for reliability, and for clinician confidence in the output. And it points back to the same foundational principle. The quality of what AI can produce is directly limited by the quality of what was documented in the first place. Centers that have invested in structured, consistent progress note documentation, the kind that AI scribes generate, find that the same structure becomes the engine for every downstream document. Centers that have not yet made that investment find that AI-generated letters and summaries are less useful because the source material is less consistent. The workflow implications here extend to supervision as well. In training environments, letters and summaries drafted by trainees require supervisor review before they go out. When AI produces the first draft, drawing from a structured record, the supervisor is reviewing a consistently organized document rather than a highly variable one. That consistency reduces supervision time on formatting and structure and allows the supervisor to focus on clinical content and professional framing. So here are 4 takeaways worth keeping. First, AI documentation does not stop at progress notes. Every document that draws from the clinical record, letters, summaries, referrals, clearances, is a candidate for AI-assisted drafting when the underlying record is well-structured. Second, the quality of AI output is determined by the quality of documentation upstream. Consistent, structured progress notes are not just good clinical practice. They are the foundation that makes every downstream AI capability work. Third, time savings compound across document types. A center that reduces time on progress notes and also reduces time on letters and summaries is capturing a much larger return than per note time savings alone would suggest. And fourth, this is a workflow design question as much as a technology question. Centers that benefit most from AI documentation across all document types are the ones that have built structured, consistent documentation practices and have an EHR that is designed to support them. If you want to see what this looks like inside a system specifically built for university counseling centers, there's a link below to connect with our team.